2, 1. We are live now.
Okay. Hi, everybody. Welcome to another evening of this session on knee imaging. We're focusing again just on internal derangements at this stage and on MRI. And it's to help you to learn how to look at knee MRIs and try and make sense of what we do and what we're looking at, and hopefully help in your practice. I've just put out some contact information again for the two course creators, Malini Lavandi and myself, Aditya Daftari. These are our email addresses. This is where you can send us stuff for second opinions. This is how you can contact us on WhatsApp, and this is where we're available for consultations. We've also got a bunch of other places across the country besides Mumbai. We also are tied up with NM Medical in Pune. We have tie-ups with centers in Allahabad, in Varanasi, in Raichur, and Amravati, and a bunch of other places which you can check out on our website. I'm going to just take off on this time session. I think I mentioned there are three things we're going to try to look at in this session. One is the patellofemoral compartment. Two is going to be the articular cartilage, and three is going to be looking at the synovium and joint effusions and synovial bodies. I think that will basically give us a relatively decent overview of most of the things that we look at with knee MRI. And what we'd want to leave for the last session is something where we can create some sort of a collective of the doubts that people have, and maybe sort of build something out from there. So we'll try and do a couple of different things. I think people wanted to see cases. Maybe what we can do is share some links to some images with people, and then we can discuss those cases next time. But I think the next session that will be there will be very much about what you want and what else you want out of this course to complete things. Okay, so let's start just quickly on MRI in patellofemoral instability. I think when we think about patellofemoral instability, I like to think about two components. One is patellar dislocation, and the second is patellofemoral tracking issues. When we look at patellofemoral dislocation, the way I at least think about things are, one is what are the effects of dislocation? What cartilage, what ligament, what structures are damaged? Then the second thing we think about is what is the cause for that dislocation? Is there something wrong with the anatomy? Is there patella alta? Is there a shallow trochlea? Are there certain morphologic reasons why somebody is more prone to dislocate? And then there are the other things of when people are dislocating, what are the things that we're going to do in order to help treat that, or what is the information that we would need that is helpful to treat those dislocations or those recurrent dislocation events. And for that, we think of things like TT-TG distance, and genu valgum and things like that. So the relevant anatomic structures with patellofemoral dislocation are no stranger to any of you. It's the patella, the trochlea, the patellofemoral ligaments, the patellar position, and the TT-TG distance. So the patella and the trochlea are the parts that generally get affected. The trochlea and maybe the patellofemoral ligaments to some extent, the laxity could be predisposing causes, and then there could be management. So some of these are affected, some of these are predisposing causes, and some of these are important in management. So what are the effects of patellar dislocation? So injury-related change. So anytime a patellofemoral dislocation event occurs, we will have changes on the patella, we will have changes on the trochlea, and we will have involvement of the medial patellofemoral ligament, assuming most patellofemoral dislocations are lateral. So effects on the patella, if we think about it, we have a rupture of the medial patellofemoral ligament as the patella dislocates laterally. And you can see here that there's discontinuous bone edema here where the medial patellofemoral ligament ruptured off. Along with that, you have an impaction injury at the periphery of the lateral femoral condyle, and you also have an impaction injury at the medial patella, patellar facet. Now, you can have either an impaction injury here at the medial patellar facet, you can have an osteochondral lesion here, or you can have avulsive bone marrow edema where this MPFL attaches to the bone. So you can have them from all those different reasons. So here's somebody with a classic patellofemoral dislocation. You can see that lateral femoral condyle bone marrow edema, the medial pole patellar avulsive edema, and you can clearly imagine this patella went out here, collided against here, came back. And while it went out, the MPFL got probably tugged or pulled off of this attachment here. This tends to happen at the inferior aspect. So you can see that the bone edema is more inferior here. And then sometimes you'll also see a little bit of tibial bone marrow edema. Now, what happens on the cartilage side? You can either see a contusion. So if somebody's got recurrent dislocations and they have a very lax MPFL and they tend to just sort of sublux out and impact regularly, then there is not that much of a hard impact, or this could be a younger person, and you just see a contusion along the medial patellofemoral cartilage. In some others, you can see a discrete chondral lesion. Oftentimes with this chondral lesion, there's a slender flake of bone that comes off. So on the X-ray, you may just see this very slender crescent-like piece of bone that comes off. And then sometimes you'll see here, like here, not only bone, but you can see that cortical bone is lost here. So it's an actual osteochondral defect that happens, an osteochondral injury that happens in these situations. Okay, so contusion you probably won't fix. A chondral defect, you're going to fix or decide whether you want to stabilize it or not. And an osteochondral lesion, again, you're going to decide whether you're going to fix or stabilize, depending on the size. Effects on the trochlea, as I showed you here, is basically bone marrow edema or impactional bone marrow edema from that impaction. And then effects on the medial patellofemoral ligament, you can see a bunch of different things. So here's a patient where there's the patellar chondral defect from that patellofemoral dislocation event. And if we see the MPFL here, you can see the patellar attachment is slender, but you can see there's a lot of heterogeneity here towards the patellar attachment and the mid substance. Here you can see the changes are more in the mid substance on towards the femoral side. And here you can see the changes are more towards the femoral side. Now, you know, I get calls all the time of people asking me about what is the status of the MPFL. And to be very honest, in many patients, unless there is a big avulsion, because many of these patients that we see are recurrent dislocators, they already have very slender, attenuated, and weak looking MPFLs. So when unless they are in a violent pull on somebody who's having a first time MPF, patellar dislocation, sometimes it's very hard to tell whether the injury was on the patellar side or the femoral side or the mid substance. So in these cases, we end up telling you that, look, there is attenuation of the ligament, which means it is thin and slender. And honestly, we have seen thin and slender attenuated patellofemoral ligaments even in normal patients who don't have patellar instability. So it makes it even more challenging for us to call those things. But once you have patellofemoral instability and you know that's there, then what we try to tell you is, like, for example, here you can see the patellar attachment is definitely more robust. It's got a slender band-like appearance, whereas the femoral attachment is quite sort of inhomogeneous here. And similarly, here you can see the patellar attachment is a little bit inhomogeneous, but again, this mid substance and femoral attachment is quite bad. And here you can see that it's actually more towards the patellar attachment and the mid substance that it's quite bad. So they can be, you'll have these patellofemoral ligament injuries, and these are challenging to describe in the way that you would like them described. Okay. Now, what are the things that can predispose an anatomy that can cause it? So some of the things that we look at are obviously the patellar position. So we measure the insult-Salvati ratio, which is the patellar length to the patellar tendon length. Nowadays, there's a greater preponderance to measuring the Caton-Deschamps ratio, which is the patellar articular surface to the patellar tendon breadth. And then we look at whether there is a high riding or a low riding patella. And then we look at the patellar shape. Now, from what I understand, patellar shape does not play a massive role in patellofemoral instability, but nevertheless, we do describe it. We look at the trochlear morphology, and the standard thing to do is to look at it using the de Jure classification. So here you can see a type A, where you can see it's just slightly shallow, a type B, where it is pretty much flat, a type C, where it is sort of starting to come down and it's almost more convex, and there's some medial hypoplasia. So here you can see the medial facet is significantly smaller than the lateral facet. Normally, these should be in about a 60-40 ratio. And then here you can have this sort of cliff hanging sort of fall off sign in a type D. We can also give you measurements here for the trochlear sulcus angle, the lateral patellar inclination angle, and a bunch of things. Just remember that the position of the patella in relation to the trochlea can change when we put somebody into an MRI scanner, because we put padding around the knee to keep the knee stable. And if you have a very lax patella, that patella can move from one position to the other. So we don't normally talk too much about patellar position in relation to the trochlea on an MRI scan, because it's not as reliable. Okay. So we can, and then we can measure all the standard. And here, I guess the concern is whether somebody wants to do a tracheoplasty. Now, the couple of other things that from a surgical decision-making perspective are important to you are the TT-TG distance, and if there is any excessive valgus. So the TT-TG distance, now what is important when we do the TT-TG measurements is that the patient position is with the toes pointing up and next to each other, and they're not externally rotated. The moment they externally rotate, then the TT-TG distance can get altered quite significantly. What we do in order to measure the TT-TG distance, I'm going to try and show you a scan here. Just give me 1 second. So I can show you that in a little bit more of a systematic way. So let's put this here. Okay. So what if we wanted to measure the TT-TG distance on any patient? What we can do is we basically try to put both scans right next to each other, the sagittal as well as the axial. So here we are. What we try to do here is we try to get to the middle of the trochlea, right around there. And this point here, which is the trochlear groove, we mark that. Okay. Next, what we do is we scroll down all the way down to the tibial tuberosity, and we try and find the center of the tibial tuberosity of the patellar tendon, which is here. We copy this marker from this point, and we scroll up again to that point where we marked the center of the trochlear groove, and we paste this here. Now what we want to do ideally is we normally do some crude measurements, but here we draw a line that goes across the posterior intercondylar axis, and then we drag that line up here, and the distance between these 2 points then gives you the TT-TG distance. Okay. Some people ask for something that is called superimposition of both the images, and what we do there is we can take, and this is just playing games with this data, we take these 2 images together. What we do is we turn off the sync. So we, sync series, we turn off. And what we do is we can literally on software like Horos, which is a very powerful software, we can take this image and we can just scroll it over and we can fuse this image against this. Now what we do is we go down and we scroll down. And as we scroll down on this image, you can see that this is where the we scroll down all the way to the tibial tuberosity, and you can see here that this is where the center of the tibial tuberosity is. This is where the trochlear groove is on the other image that we had, and then similarly draw that line. So these are just a couple of ways in which you can do it. It does involve some element of image manipulation to do it, or trickery, but it's certainly very easily doable with most modern softwares. Coming back to the talk here. Some of the things that I find are important to talk about with the TT-TG distance are there is a known publication that says that MRI underestimates the TT-TG distance. So be aware of why, of when you measure it just on MR. The second thing that tends to happen is that the TT-TG distance actually tends to be is very dependent on patient positioning. So if somebody is doing this, we should make sure that the imaging center is aware that they're doing the TT-TG distance and that they are putting patients into the scanner in a fairly standardized position so that that measurement is accurate. Now, that being said, in my own personal experience and an experience of some other senior radiologists around the world who I've spoken to, the TT-TG distance measurement that we do, whether we do it on MR or on CT, tends not to be that great in terms of reliability. In other words, if we scan the same patient in the same position on 2 occasions, we can potentially come up with 2 relatively different appearing TT-TG distances. And I'm not entirely sure what the reason for that is, but it's certainly something that I have noticed. And therefore, I always warn orthopedic surgeons when I tell them about the TT-TG distance, that these are the measurements I'm giving you, but you will need some further sort of evaluation for that. Okay. Now, the other things that we look at obviously are genu valgum and the Q angle. Now, in order to do this, one has to actually take a fairly large image on CT. But I think these are probably better assessed on standing scanograms than doing CTs. And so that's what I would sort of recommend in doing, and that's what at least the orthopedic surgeons in our practice use. So again, if you have extensive valgus, somebody can consider a DFO for that. So when we think about the anatomy from a patella perspective, we can say that the patella is usually affected. So we look for osteochondral lesions. We look for predisposing causes in terms of patellar morphology, and obviously patellar lesions oftentimes will require management. On the trochlear perspective, it is often affected because there's impaction there. You can obviously have predisposing anatomy that is abnormal in the trochlea, which would include a shallow trochlea or a hypoplastic medial flange, etc. And the role of trochleoplasty is something that's plus minus. I think we've seen very few of them in our practice in general. The patellofemoral ligaments, again, are very affected. In terms of the predisposition, somebody having a congenitally lax patellofemoral ligament, I suppose that's a possibility. And in terms of management, yes, you do fix them often. But on MRI, we can tell you that they are slender, they are attenuated, they are more affected towards the femoral side, more affected towards the tibial side. But I think procedurally, you end up reconstructing the entire ligament. So I'm not sure how much information that adds. Obviously, if there's a bony avulsion or something like that, that would be important. Patellar position is usually fairly standard, but it is a predisposing cause. So patella alta obviously predisposes you to patellar dislocation events. And patellar position, you can change in management when you do a sort of a distalization of the tibial tuberosity. And the TTTG distance is again something that is not affected by patellofemoral dislocations, but it is a predisposing, or abnormal TTG distance could predispose you to it, and you would do something with management for that. Moving from patellofemoral instability to the patellofemoral friction syndrome, I think this is another area that comes up. We have patellofemoral pain syndromes, and in these cases, people are looking for either some element of soft tissue edema, usually at the inferolateral pole of the patella in the patellofemoral fat, and then that often is an area for impingement. We can look at patellar tracking. So usually if things are going to go wrong in supination, they would be out. And then as you flex towards 15, 30, and 45 degrees, it comes back centrally. And this is essentially a depiction of a typical J sign that you would see clinically. So it's subluxed in supination, and as you get to 15 degrees, it starts to engage and comes back into place. So in summary, when we think about patellofemoral instability, there are two aspects. There's dislocation or subluxation, and there's a tracking abnormality. In dislocation, we always think about the effects of the dislocation, which is typically the patella, the trochlear, and the MPFL. The predisposing factors are patellar position, trochlear dysplasia, and the MPFL. And then we think of the surgically important issues, which are osteochondral injuries, the MPFL, TTTG distance, and excessive valgus. And when we think about patellar tracking issues, we think about patellofemoral maltracking, and we think about the patellofemoral friction syndrome. Just in the interest of time, what I'll do is I'll go through the entire talk, and then we'll give ourselves time to go through questions if that's okay with everybody. Do we see any questions or concerns otherwise? Okay. So moving on from patellofemoral, but in a somewhat related way, we talk about cartilage lesions because we do see cartilage lesions oftentimes with patellofemoral instability. The essential role for MRI in assessing cartilage lesions is to identify that there is a cartilage abnormality, characterize it. Is it a softening? Is it a contusion? Is it a flap? Is it a defect? Is it a degenerative defect? Is it a discrete defect? To quantify it, give it some size. And then if you've done something to it or whether you've not done something to it, to follow up. Has it gotten bigger or smaller? Has it healed? What is happening to it? So in order to sort of understand this, I think some of you will be familiar with normal cartilage structure. And the key things over here are cartilage consists of collagen, well-ordered collagen at the articular surface. So it is collagen fibers that run parallel to the articular surface, which is the superficial or the tangential zone. And because the cartilage is really tightly bound here, there's very little water in between. And so this area appears extremely dark. Okay. Similarly, in the deep zone, because they are sort of perpendicularly oriented and fairly tightly bound, again, this area appears dark. Now, in the deep zone, you have a portion of this that is connected to the lower bone. So it's calcified, and you have a portion that is non-calcified. And the transition point between the calcified and non-calcified cartilage is something that we call the tide mark. And we use the term tide mark because if we think about it, when we go to the beach and you see waves coming up onto the shore and then receding back, the line that it leaves on the beach, that's called the tide mark. So this is called the tide mark. And this is particularly important because the cartilage below this is calcified, above this is not calcified, and therefore this below is stiffer cartilage, this above is softer cartilage. And so if you were to think of somebody pushing this cartilage from here, obviously the softer cartilage would move, the stiffer cartilage would not move, and therefore you would start to develop cartilage shearing injuries along this line. The middle zone here, or the transitional zone, is a place with spongy cartilage. It's got disordered collagen, it's got more mobile water, and therefore it appears slightly gray. And I'll show you what the image of all this looks like. Is this on this inverted patellar image? So this is the patella just turned upside down. You can see here this superficial region, which is thin, which is this black line. You can see this middle zone here, which is the transitional zone. And you can see this deep zone here, that is essentially the this darker area here, which is your deep zone. You can see here that there's a chondral fissure that comes down into the transitional zone from the superficial zone and gets to the articular surface. So this is fairly classic sort of cartilage appearance on a normal proton density image. And you can see that we can see such great detail of articular cartilage on a regular proton density image that is done well. Okay. Now, if we think about this, we have other methods by which we can look at it. So here, if you look at a T1 weighted image, a T1 weighted image does not show you fluid very well. And therefore, it is very difficult to discern a cartilage defect on a T1 weighted image. On a T2 weighted image, you can see that this is an area where cartilage has been disrupted. That normal gray anatomy has gone. You have disrupted cartilage, and therefore it has fluid signal, and you see it quite discretely. And similarly here on this proton density image, also you can see it quite clearly. And on top of that, what you can see with these proton density images really is you can sometimes see the detail of the cartilage defect a little bit better, because these are better resolved images than the fat suppressed images. A gradient echo sequence is another sequence that people have used to look at cartilage. What this does is it separates cartilage out from all the other structures. It suppresses fat, it suppresses bone, and it just shows you cartilage. The problem with this sequence is that it usually takes a lot more time to acquire, and it only gives you cartilage image. It doesn't give you any other information. And in day-to-day practice, we find that doing proton density images give us about as much information, if not more, than these SPGR images to get things. But when you have these images that are well taken like this, you can do quantification studies and research studies on cartilage if you want to, which just sort of makes it a little bit more exciting. So on high resolution proton density images, here are some examples of patellar cartilage. Here's the trochlear cartilage. You can see the dark superficial zone. You can see the gray transitional zone, and you can see the darker deep zone right here. You can see this superficial chondral fissure here in a grade 1 chondral fissure. Here you can see grade 2 going through 50% of cartilage and starting to shear laterally here as well. Here you can see a grade 3 lesion. So you see how that lesion has tracked through the superficial layer and then gone right down to that radial zone and is forming that radial zone flap. And then these are the cartilage lesions that sort of delaminate really fast and lead to progressive rapidly progressive osteoarthritis. Here's another more discrete chondral lesion here. And here again, your sort of grade 3 complete thickness cartilage loss. Okay. So what we can give you on MRs, we can give you the size, the site, the extent, as well as the status of the subchondral bone. And then based on that, you take a call on whether you want to leave it, you want to use biologics, microfracture, OATS, or ACI. Now, what I've showed you was more sort of how morphologic imaging works. Like what is just, how thick is the cartilage? What is slight abnormalities in the cartilage? What people oftentimes want to do is they want to look at the ultrastructure of cartilage, and they say, I want to see the ultrastructure. Now, to be very honest, this is very much, even though it's been there for many, many years now, it is still very much in research vogue, and the clinical applications are quite limited unless you're actually doing cartilage surgery regularly and you want to follow up cartilage. Okay, so what are the ways in which we can look at this? One is we look at collagen organization. So if you have, as I mentioned previously, very well organized collagen, things will appear black. And if you have disordered collagen, things will appear gray. And based on as collagen gets more and more disorganized, it will move from gray to absolute bright signal. Now that can be expressed in a color scale and by using different imaging sequences to give you what are called T2 maps. And this is what most of you refer to as cartograms. Okay, so this is one thing that we can do. The other thing that we can do is we know cartilage consists of glycosaminoglycans. Glycosaminoglycans are negatively charged. And when we inject intravenous contrast into the joint, what ends up happening, or into the intravascularly, what ends up happening is that contrast material will concentrate in cartilage to different degrees. So because contrast material is negatively charged and glycosaminoglycans are negatively charged, normally when you inject contrast, cartilage will not enhance so much. But if you have degenerating cartilage, you have less glycosaminoglycans, and the contrast will enter the cartilage and you will start to see increased uptake. So this is just physiologically what people talk about. And then there's another technique called T1 row imaging, which also gives you a good idea of glycosaminoglycan stuff. But in general, what we find for day-to-day work, proton density images are more than adequate. They give you a sense of disorderliness. So you can see here, this is relatively normal cartilage. This is abnormal cartilage. They give you a great look at the anatomy. You can see this discrete delaminating flap coming in here, and they give you a great look at the subchondral bone. So personally, the number of times that I feel the need for a T2 map or for a GAG study or any of these things is negligible. And and the other thing that I want to tell all of you that I see oftentimes showing up in my practice but is not needed is when you're looking for somebody with osteoarthritis, you absolutely do not need to do a cartilage map. For osteoarthritis, your regular proton density images are absolutely more than adequate. So will these other techniques like T1 row and P2 mapping, will they help us to identify susceptible cartilage? I don't know. And what will we do about it? I don't know. But here's an example of how we use this. So if we look at these two image sets here post microfracture, what we see here is actually the cartilage looks quite congruous and seems to have done quite well and healed well. But when we start to look at the T2 maps, you can see there's a change in the T2 relaxivity in this area. And that probably is an indicator that this is not hyaline cartilage, and this is probably fibrocartilage, and because it has a different relaxivity as compared to the adjacent articular cartilage. So for whatever that's worth, you get that information. Now, moving on from these discrete cartilage lesions to osteoarthritis, today we find that in a vast number of practices, especially ours, almost always people will end up doing MRIs before they do a knee replacement surgery. And the reason is because we are finding more and more that radiographs are not necessarily the greatest indicators of the status of articular cartilage in the knee. And especially in today's day and age where we're thinking about knee preservation surgery, what we are trying to determine is truly how bad is the cartilage. Is there a lot of cartilage loss? Is it more on the femoral side? Is it more on the tibial side? Is it, on both sides? Is it medial compartment only, lateral compartment only? And I think an MRI is very helpful in doing that. So we have plenty of cases where medial compartment osteoarthritis is underestimated on X-ray. So for example, here you may not see there's a lot of compartment narrowing because this is ovoid and slight obliquity. But if you see this, you can see there's complete femoral sided articular cartilage loss. You can see that there is tibial sided cartilage. So just in the way that we have gone from a world where we used to think that all OA should be treated with a total knee arthroplasty, we have moved to now unicompartmental because we are seeing medial compartment involvement and spared lateral compartments. The same thing I'm seeing as a trend is where I'm seeing a greater involvement of only the femoral side and not really the tibial side. And, there is, as many of you know, there is early work on doing sort of even just a quadrant arthroplasty where you just replace a part of the femoral condyle. So this is just some of the stuff that I think where MR will play a role in osteoarthritis. Now here, for example, in this case, one would have thought that there is involvement of the lateral compartment here with the osteophytes and with this bone spur here. But as it turns out, the medial compartment is completely gone, but lateral cartilage is pristine. And so this is a patient who would have otherwise undergone a TKR, but just went to a high tibial osteotomy because he was young, or in an older patient may go to a unicompartmental arthroplasty. So when we think about cartilage imaging, some take-home points for you: the proton density and proton density fat suppressed images reliably identify and characterize most chondral lesions as well as the subchondral bone, which is more than adequate for chondral surgical planning. The ultrastructure imaging like T2 maps, T1 row, double contrast imaging, they may give us an idea about collagen and proteoglycans, but I don't think we really know what to do with that information in most situations. T2 maps may have a role in assessing post-operative cartilage and showing that, okay, we've got similar cartilage characteristics to normal cartilage, and therefore this is hyaline cartilage and not fibrocartilage. And in diffuse chondral disease today in preoperative management, I think a lot more patients are undergoing MRI to determine whether they truly have unicompartmental or multi-compartmental disease. And I think in future, we will play greater roles in terms of understanding what the wear patterns are, and then, further reducing the surgical, the surgical changes that we perform in order to extend the life of the native knee. Now, lastly, before we go to questions and everything else, I want to just talk a little bit about synovium, because on the chat, there were questions about showing cases about PVNS and other things. Now, what I've tried to create here is a small little flow chart for you to think about. When you think about synovial things, we think about the synovial bodies and we think about thickening of the synovium. If you think about synovial bodies, you think about single bodies and multiple bodies. If you see a single body and it is ossified, then obviously it's an osteochondral body. The one thing that the couple of things that I would warrant you to think about when you see an intra-articular body, if it's along the posterior horn of the medial meniscus, obviously think about a meniscal ossicle. I think that's the main sort of ossified osteochondral body that you think of. And the other one, for sometimes people may mistake the fabula for an intra-articular body behind the lateral femoral condyle. And if it's a non-ossified body, then you have to start thinking about PVNS, a chondral lesion, so just a chondral body, or some meniscal flap or fold that's flipped over somewhere. If you see multiple intra-articular bodies, try to describe whether you think they're small, regular, sort of homogeneous sized bodies. If they do not contain fat, then they are probably rice bodies or primary osteochondromatosis. And if they do contain fat, then it's lipoma arborescens. And most of the time, this will be associated with an osteoarthritic knee. If you have large irregular bodies, then you obviously think of secondary osteochondromatosis. And when we think about synovial lining, if you think it is thick or thin, but it is smooth, then we call it reactive. If it is irregular and thick, but has dark components, then it could be because of hemosiderin staining from a previous hemorrhage. If it's nodular, you could think of the diffuse form of PVNS. If it's diffuse, just thickening, but not really very nodular, then you could think of arthropfibrosis. And if it's got edema associated with it in a heterogeneous appearance, then you think of infection or inflammation. So here are some examples. So here's sort of smooth synovium with a little bit of nodularity, but overall smooth. This I would call reactive synovium. Similarly, here you can see thick but smooth synovium, and this we would call again reactive. This is in a postplasty patient. You can see thick, you can see synovium that's thick and smooth, but you can see these small little particulate bodies in it. So this is a particulate synovitis. And then last but not least, you can see here a very heterogeneous one, which is infectious. Give me 1 second. My daughter is actually practicing her music at the loudest possible way in the most inappropriate time. Just 1 second. We maybe do with 1 second. She has apologized profusely, but remains unrepentant. Okay, so now when you think about this, so here we have intra-articular bodies. Now here, this is a more discrete nodule that you can see here. Here's again a more discrete nodule here. And this is pretty typical of focal form of PVNS, or what we call nodular synovitis, which is the focal form of PVNS. Here, on the other hand, we have a case where you can see this nodule, but we also see that there's a lot of nodular thickening along the synovium here. You see that there's intra-articular fluid also, and that makes this the more diffuse form of PVNS. Here you can see these small, little, relatively homogeneous, tiny particles all over the joint. And this is more typical of rice bodies, which you can see in infection, in inflammation, as well as in primary osteochondromatosis. In primary osteochondromatosis, in addition to these bodies, you may see a thick and irregular synovial lining because the synovium is metaplastic. And then this is an example where you can see multiple large irregular bodies, which is secondary osteochondromatosis. And you know this is secondary because you can see over here, this is the lateral compartment cartilage, which is intact, and the medial compartment cartilage, which is completely gone. So this is secondary osteochondromatosis. In primary osteochondromatosis, generally we tend to see the articular cartilage as being intact. So here's another, just a differential consideration for you to think of. We already saw this case where you can see these dark intra-articular bodies. And this would obviously be rice bodies or synovitis. And in this case, you can see some nodular areas here. Now notice, if you look at this on these non-fat suppressed images, as well as on these fat suppressed images, the rice bodies remain dark. Okay, so they don't change their character. But if you look at this case where we're taking two images on the same thing, you can see here, I can barely see these bodies. In other words, this is a T2 weighted image where fluid and fat are both bright. And so because the fluid is bright and the fat is bright, I really can't see these bodies at all. But when I do a fat suppressed sequence, the fat becomes dark. So the fluid remains bright, the fat becomes dark, and you can see these more better. You can see these sort of nodular strands better. And these nodular strands are then lipoma arborescens, which is just a reactive process of the synovium, which we see oftentimes in osteoarthrosis. Arthropfibrosis is a situation where you'll see heterogeneous marked thickening of the synovium without any effusion. So because it's so tight, you won't really see an effusion, and that is arthropfibrosis. And compare this to your diffuse nodular form of PVNS, where you see very nodular thickening of the synovium as well as a joint effusion. So here you can see actually there's absolutely no fat even. All the space is occupied by arthropfibrosis. So just to overview, think about when you're looking at the synovium, if you're looking at bodies or you're looking at thickening. When you're thinking about bodies, whether they are single or they are multiple. If they are single, are they ossified or are they non-ossified? And if they are multiple, are they small regular ones or large and irregular? If they are small and regular, is it actually a body or is it fat? And then when we think about the thickening of the synovium, think about if it's smooth or if it's irregular. If it's irregular, if it's nodular, think about the nodular form of PVNS. If it's rather diffuse, heterogeneous, think about arthropfibrosis. And if it's edematous, think about infection and inflammation. And the good thing for all of you is you don't have to correlate clinically because you already have that information. So you don't have to ask that at all. So with that, I will end the babbling part for me. What I'll do is I'll just move over to the questions on the chat. So here, right. So there's a question here which is not clear about MPFL origin and insertion in sequence. So let me just go back to that image. So if we look at okay, so if we look at these structures here, right? These strands that you see over here, these are the MPFL. Okay, it's not like one thick structure. You can see sometimes it's a little thin band like this. So when you talk about this is the patellar attachment, and the femoral attachment is rather heterogeneous. It is irregular. It is thin. It's not a single band of tissue that you can just say. When you reconstruct a single tissue, but overall it's a band of tissue. So I hope that clarifies to you that this is the patellar attachment. This side here would be the femoral attachment, but they are quite just sort of blending into the adjacent tissues. In which cases should we ask for a PD sequence and what have we to look on? Almost all internal derangement studies are done with proton density. You don't have to ask for it. The imaging center should be doing it automatically. So proton density images is what we usually use. It's the workhorse imaging for that. It's like saying, in which cases should I ask for a light source when I do arthroscopy? In which cases should I not ask for a light source? I mean, it's that base of a question. So for follow-up of cartilage-related cases, we should ask for which image. So here the question for me to ask you is, what is the cartilage lesion that you're following? If you're following a focal chondral lesion, you have not done anything to it, and you just want to see is it getting bigger or smaller, then your routine proton density images are great. If you have somebody who has OA and you're trying to see if the OA has gotten worse or better, again, routine proton density images are fine. The only time that you'll start thinking about whether you want to do a T2 map, and again, it's not mandatory, is if you're trying to say, is this hyaline cartilage that is replacing the gap? So if you do a regular proton density image, you'll see the gap is filled with tissue. Sometimes you'll see the signal in that tissue is also different from the adjacent cartilage. So you'll know this is not hyaline cartilage. But a T2 map is a way of giving you a little bit more of a sort of extra oomph to tell you that, yes, this is hyaline cartilage, or no, this is not. Can we quickly see a few patellofemoral cases? Yes, we will look at that in a minute. PVNS question mark. I showed you cases of PVNS. I'm not really sure what you are asking me over here. When there is hyperplasia of the medial femoral condyle as in 3 or 4, why should the patella dislocate laterally? That's a great question, but it does happen that way. I'm not sure of the entire mechanics of it. I think it may be just related to the way the pull works out. How to differentiate between MPFL tear and MPFL strain? That is a very, very hard question, Arun. In terms of, like I said, oftentimes when you see soft tissue edema, you can assume that there has been some tearing of the fibers. And again, I will ask you the question very simply. When do you reconstruct an MPFL? You reconstruct an MPFL when you see recurrent dislocation. In that case, you asked me about the quality of the tissue. I can give you something. But even if it's robust quality, if the person is dislocating repeatedly, you are going to reinforce it. So I don't even understand the entirety of this thing. The reason that I could give you that would be useful to understand about the MPFL is if I tell you that there's a bony avulsion that is sizable. Then when there is a bony avulsion that is sizable, then I can tell you that, okay, this is the size of the avulsion. You can fix bone back rather than just doing something else back. See that. What is the role of the lateral patellofemoral ligaments and how to? The lateral patellofemoral is actually more robust. So you can see here, this is the lateral patellofemoral ligament here. Both ligaments together play a role in stabilizing the patella. I think the biomechanics of the ligaments and how they work and function is a little bit beyond the scope of what I know, and I'm sure there are people in this audience who would know better. So why would I? So honestly, the Weiberg classification of the patella, you can just I can Google it. I can show you, this shows you different shapes of the patella. I don't know. I've never found, most of the surgeons that I work with don't really care about patella morphology in terms of its use. I think that may be a little out of a syllabus question for me in terms of why it's not used as much. Or what is PVNS? Sorry, your question here is PVNS is something called pigmented villonodular synovitis. It's a situation where you get a little nodule that forms inside the knee. It comes in two forms. One is the focal form, which we call nodular synovitis. Histopathologically, it's similar to what is called a giant cell tumor of tendon sheath, and that's what it is. And you have a more diffuse form where you have these nodules forming all over the synovium, and they have a tendency to, once the diffuse form has a tendency to recur and cause more problems. Okay. We show some cases of cartilage lesion. So I have shown you some cases of cartilage lesion. I'll try and show you. TT, PCL distance, and where do you prefer it? I unfortunately don't use this much more. So that is one more thing. A few points on how to identify patellar tendon rupture and quadriceps rupture on MRI. Yes, I will show you some of those. So let me just, let's go into some more things here. Oh, sorry, I just stopped my sharing for some reason. Okay, I will just get into it. So we wanted to see some cases of patellofemoral dislocation. So let's try and see one at least of that. Just give me a second. Sorry, I'm just going to try and open up a couple of cases. Give me a minute. So we said we want to see a case of patellofemoral dislocation. So let's do that. I'm just going to open up these couple of these cases so that we can look at those. Hmm. Okay, so patellofemoral one. And we want to see some cartilage lesions. So let me just see. Okay, let's open one of those. Sorry, everyone, for this. I'll just take a minute to. Okay, let's start with this one. Let me share my screen again. Okay, so here's a case. You can see this lateral femoral condyle impaction injury. You can see over here that we have this soft tissue edema along the inferomedial patella, right? You can see, interestingly, when you look at this edema, this is an edema pattern in the lateral femoral condyle, which you could very easily mistake for somebody who has an ACL tear. But when you look at the ACL here and you scroll through, you can see the ACL is bang normal. You can see that on the femoral side as well. And you can see here, this is the patella. When we notice sort of as we scroll across here in this case, that this is the inferolateral patella. This is the patellar attachment. So we're coming more laterally here. I mean, sorry, medially here. So this is the medial patella. You can see as we scroll up and down here, this is actually the MPFL. Now, for those of you who are talking about this, you can see here, this is the MPFL at its patellar attachment. This is it coming down all the way to its femoral attachments. You see this is the femoral attachment. As we sort of scroll up, you can see the patellar attachment. And you can see in this case, this patient has sort of an intermediate grade patellar attachment thickening of the MPFL. So again, even though this patient has sustained a patellofemoral dislocation, you can see the classic impaction pattern laterally. This probably was in a lot of flexion when this patient had this dislocation. You can see the bone marrow edema. You see that the medial patellofemoral ligament remains in continuity and that there is an intermediate grade injury at the patellar attachment, but it's not actually ruptured and come off. Okay. Sometimes some people will do CT cuts. So some of the people will do CT cuts on these patients. And as you look at the CT images here, sometimes, let me just do this here. You'll start to see some element of bony remodeling at the inferior pole where that dislocation happened. So it's just sort of an impactional change that you have there. So this is sort of one thing that we would see. Here's another case now. So this is a case where you can see here, this is your, for those of you who asked for that quadriceps tendon rupture, you can see the patella here, you can see the patellar tendon here. Now what I want to show you here is, you can see the patellar tendon being intact over here inferiorly, right? And you can see how this patella is sort of tilted off. If you look at this last case here, where we looked at the patella, you can see the patella is sort of in position here. You can see here that this patella is sort of tilted off. And when you look here, you can see this is the quadriceps tendon that is completely discontinuous here. Now, what you need to do is you need to scroll all the way medially and all the way laterally to tell that this entire quadriceps mechanism has come off. So here I'm going to show you on these non-fat suppressed images. You can see here as the patellar tendon comes up, you can see that this is the lower pole of the patella. You're crossing the patella. And now as you get to the top, there's this, which is the striations of the quadriceps mechanism. And as you come sort of a couple of sections down, you will notice that it just sort of goes missing right around there. And that's much better to see on the sagittal image. So this is a full thickness quadriceps tendon rupture. Let's see if we can get something more on this case. It's not loading. Here we go. So here's another case. And similarly here, you can see the quadriceps mechanism here. And now here, if we look at this, sort of more, let's look at both these things together again with the line. So you see this here, as we go up here, you can see we are currently sort of more towards the, let's see here. So this side here is medial, this side here is lateral. As we scroll medially, you can see that the quadriceps tendon is intact. As we come laterally right around here, you can see there's a complete defect in this quadriceps tendon. And if we scroll upwards, you see the same thing. You can see the medial aspect of the quadriceps tendon here, but you can see that there's a tear of the lateral half of the quadriceps tendon. The lateral sort of patellofemoral, the lower end of the vastus lateralis is intact here. And then here you can see the VMO is actually intact here as well. Okay. So that's one more example. Let's just see this one more case. Okay. Is there any questions here? Okay, so I think if we're looking at measuring trochlear depth, so I think there's a lot of questions people ask about how to measure these things. I'm really not even sure how often people use these measurements, but if you had to measure the trochlear depth, typically what you want to do is you want to go, I'm going to show you some cartilage cases in a minute, don't worry. Typically what you want to do is you want to get your axial image towards the center of the trochlea. So scroll down till you're somewhere close to the center of the trochlea. And then right at this point, you can just take an angle measure and you can go measure the cartilage by bone and you'll get your angle of what the trochlear depth is. I'm going to stop sharing for a second and I'm just going to get us some cartilage cases. So body part. Sorry, 1 second. I just. So I show you two cases here that so resisting so long to load. Sorry, just give a second here. Okay. And okay. So here's one case that is kind of interesting. Let me just share my screen again. Okay. So here's one case that's kind of interesting. So here we have a case, patient who comes in with knee pain. And you sort of scroll through these images, and one initially may not really see much over here until you start to sort of go and you scroll a little bit further, and just get a different mouse so you can scroll a little bit more easily. So this is kind of a tough case, but this is the kind of lesions we see sometimes. So you can see here that there is this cartilage flap over here. You see how this cartilage is relatively normal, and you can see that there's this flap over here. And if we scroll across this, you can see here, maybe if I show you on a non-fat suppressed image. So sorry, I've got to get rid of the patient name. Let's get rid of this. So if you see this, this is the trochlear cartilage. This is the patellar cartilage. Now, as you scroll towards the side, let's get towards medially, you can see this fine. As you come laterally here, you suddenly find that there's an area here that the cartilage is lost. This whole area here from this thing. Notice how this cartilage is pretty thick and nice. And as you move laterally, there's an area where you lose cartilage here and then it comes back. And these are kind of, these are hard cases, but I think they illustrate the point nicely, because when you get to us and you send us somebody who's got a patient with anterior knee pain and we send you back to saying we don't know what's going on, as opposed to we tell you there's a discrete cartilage defect and we give you a measurement for it, I think it helps you, even if you're not going to fix it, to sort of help, to figure out what you're going to do next. Now, here's another sort of interesting case. So we have this case here. Now, this is 8/26/22, and this is 2017. And, this is again a case where we sort of look at this, just trying to figure out which exactly thing we saw here. Give me 1 second. Now, just find a better case. Let me just show you something more obvious so I don't confuse you. Give me 1 second. I'll just find a more obvious case. Just give me 1 second. I just find it easier to show you a talk that I have with this thing. Okay. All right. Sorry about that. Okay, so here are some cases where of cartilage lesions. So focal cartilage lesion. So here is an example of someone who had an Oates procedure, and you can see that this is where the harvest site was. This is where the plug was put in, and the plug has actually come off, and there's no defect. So it's a failed mosaic-plasty here. This is a patient where you can see that the patient had an Oates procedure. The plugs are all fine, and you can see really in how much detail that there's just this fissure in the cartilage anteriorly, and posteriorly there's condyle thinning. Okay, so the cartilage is not entirely normal; it's slightly depressed. Here's an example of somebody who had an Oates procedure. You can see this is the Oates plug over here and over here. And you can see how those plugs have integrated well. And you can see the overlying cartilage that has filled the gap. You can see the cartilage is flush to slightly proud, which is exactly what we want it to be. And you can see that the cartilage signal is slightly different from the adjacent cartilage, but it is sort of what it is. And this is the cartilage harvest site. Okay. Here's an example of somebody who had an ACI. So this is May 2010. This is September 2010, and you can see that in May 2010 there was cartilage here, and you can see that September it sort of healed nicely. This was the micro fracture case I showed you earlier, and you can see how the T2 map shows you that there's altered T2 relaxivity in the area of microfracture, indicating that it is replaced by fibrocartilage. Here's a full thickness chondral defect here. And this you can see now this patient has undergone microfracture, and you can see that there's early fibrocartilage formation in that gap. Okay, so you can see that there is some change happening here. Here is an osteochondral lesion. So you can see the chondral flap. You can see it delaminating down here. In 2019, you can see how it starts to heal because this is just periosteum lifted off here. And then here you can see furthermore and later on how it's healed completely. Here is a patient who has an osteochondritis dissecans lesion. You can see this here. You can see how actually the bony component and the cartilage component, how this fragment is actually flipped on itself. And there's clear fluid separating it from the adjacent structures, indicating that it's an osteochondral lesion. And here you can see that this is somebody who can see the osteochondral defect here, and this is the displaced chondral fragment here. And here you can see just healing with just a little bit of bone edema and how cartilage has reformed to fill the gap of an OCD lesion. Here you can see a cartilage defect in the patella, and you can see here that this is the radial zone shearing in this side. So when you put a scope in here, you see bald cartilage, and when you flow some fluid in here, you'll see this cartilage sort of flapping out here as well. And you can see this here on the sagittal image, how this is actually the entire delaminating flap craniocaudally. Okay. This I already showed you in terms of articular cartilage grading as it being grade 1, 2, and then 3 with the full thickness defect. Here you can see the site of this defect is a full thickness chondral defect in the patella, and you can measure that quite nicely. So this is sort of what some of the things that we can do with cartilage. Okay. Let's see, are there any other questions? I hope that gives you a good sense of what we're looking at and where things are at. I'm not sure if there are any other specific questions that anyone has we can answer. Okay, well, if that's the case, then we'll stop with this. I think if you can put up a, I hope over the next week we can put up some more. What we'll try and do is give you some cases which maybe we can go over the next time. And then what we'll also try and do is hope for all of you to put some questions up, which we can maybe consolidate and make the next session about answering some of those, or at least clarifying some of those things. I hope the sessions have been helpful to you. I hope they've been in some way given you some direction on where to go with imaging. And obviously you have the WhatsApp chat to send any feedback or concerns. If you feel you want to share them privately, feel free to send them privately, and I'm happy to sort them out as best possible. Okay, thanks very much, everybody. Really appreciate your time, and look forward to seeing you next week.